Hi everyone, welcome back to the hashtag #CArthritis Facebook and Twitter live event at this year's Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting. I am so excited to be sitting here. We're rounding the corner now, rounding the corner into the home stretch of our event, and as is the program chair here, the scientific program chair, Dr.Vinod Chandran. You have masterminded, not just this year, but the two previous years before it. This is the first year back in person. We're so excited to be here as well, again, hosting our booth and talking to all of the experts, your colleagues, yourself, about the science and the clinical practice advances that have been made over the last year. And obviously to be doing it in person. So thank you for coming. We're very appreciative. We know you've got lots of other things to do as program chair, so we're not going to keep you for long. But really what our audience wants to hear from you is tell us about this year's meeting, your general impressions. I know you're a busy person here at the meeting and you've been in and out and leading some of the sessions yourself. But what have been your observations, your aha moments, so to speak?
Right, yeah, thank you, Cheryl, for having me back. The last time we did was 3-4 years ago when, I think in
Victoria, yeah.
And that meeting was when I took over the chair of this, and that's 3 years ago. And by the way, you're a chair for 3 years, so now this is my last.
They're throwing you out now?
I'm out now.
You're out.
Yeah, so, and then we had the meeting, and on the way back, is when COVID actually hit us, all of us.
Very clearly.
And then for the last 3 years, we have had this virtual meeting. We have planned, we planned to come to Quebec City in 2001, right? And so it's been taking 3 long years to get here finally in person. And it was strange planning everything. Of course, we planned things online. We moved to Zoom because we had another technology before, but Zoom, the pandemic gave us Zoom for us to
works great,
work.
yeah.
But we missed that, people coming in, and so last year we almost got back in, and then we had to abandon it after the another wave of COVID. And now we are finally here. I think most of the attendees came in person. That was about 20-25% who were online.
Okay.
So great attendance. Everybody's so excited to meet, and some hug, but at least shake hands.
What I love is the lanyard approach. We've taken our badges off, but they're green, yellow, and red. Some people are masking, some are not. I have 5 vaccines and have had a mild case of COVID, so I feel pretty safe. So everyone has their different tolerances. And I really appreciated that as an attendee myself. Tell us about this year's theme.
Right, yeah. And so thinking about all the things that has happened over the last 3 years, all the crises that we're still facing, and the need to reconnect and to reimagine. Our theme is to reconnect, reimagine, and I should look at my notes here because I keep forgetting it. Renew. That's what we need to do.
Yeah.
Right? We need to reconnect. We need to renew because yes, some things have become a little difficult, but then we got to reimagine. And as healthcare is facing lots of challenges, I think going back to the so-called normal is not going to happen anymore. We need to think better way to increase efficiencies, and virtual care and other things are here to stay, and which is not. People thought that was not really what we could do, but it has a role. Not everybody is served well with virtual care, but there is a role for virtual care in rheumatology because we, as rheumatologists, we really want to feel the joint, and so we always were a little not like dermatology. You look at a picture and say, "Yes, I know what your diagnosis is."
Exactly.
So that was a real challenge. So seeing is a really important, feeling a physical exam. But once you do that, a lot of things can be done, online counseling, for example, and taking care of some of the urgencies that could be done by Zoom. So Zoom or some of the other virtual platforms, secure ones.
Yeah.
So we're thinking of that. We're looking at, and over the last 3 years, a lot more technologies continue to advance, and how can we leverage that both in the medical side of things. Vaccines are a great example of how things could happen very quickly.
Right.
And then also looking at data and how we can use machine learning and other methods of artificial intelligence to kind of start understanding disease better. And there's this tension in rheumatology between lumpers and splitters. It's, you got rheumatoid, put all the rheumatoids together.
Yeah.
And then the splitters saying, no, you got this type of rheumatoid.
We want to tease it all apart.
Tease it out so that we can have a better, more homogeneity, because all our diseases are heterogeneous, and bring that homogeneity would help us predict what's going to happen from a disease course in the future, and so have better targeted therapies.
So it sounds to me, you're talking really kind of in lay terms. This is the scientific way of getting at that personalized medicine we hear about and read about in the mainstream media, which is super exciting, because as a patient myself, and we represent 50,000 of them across the country here in Canada, and talk to many more than that on a daily basis. If we can have confidence that the first thing you and I decide to do, whether it's a non-medication treatment or a medication treatment, that there's some science behind that choice, is like amazing. I mean, I've been having rheumatoid arthritis for 33 years now. And we're so much further from when I started in those conversations with my rheumatologist than you and your current patient. It's amazing how I've seen rheumatology pivot through the pandemic. I agree that virtual care is not going away, and it shouldn't. Yep. We did a lot of survey work during the pandemic, actually early on, and I'll be talking about it on a panel with some of your colleagues, Dr. Levy, Vandana Ahluwalia, and a few others, who are going to share our various perspectives on virtual care and what happened and where we think it's going and where it should go. What are your views on that? What was your experience with your patients? I hear you when you said you really needed that physical touch piece and are getting that back. But the role of virtual care is still very real. It's very beneficial, I think. Our data showed that people were more comfortable sharing their concerns in a virtual setting than they were in your office. Do you find some of that with some of your patients?
Yeah, I think when we have a virtual, the time that we spend together is pretty much the same, right? And when you're meeting in person, we from a rheumatology point of view, I think clinicians think we need to spend the bigger chunk of time actually examining and finding out what's going on, which gives the patient and physician that discussion of concerns, I think, sometimes gets truncated. And you're like, oh yeah, we can discuss it next time. Oh, I've seen your joints. Okay, let's do this. And it's very medicalized. Yeah. Whereas when you're doing in a virtual environment, there's no physical exam, right? At least I don't. Some people say yes, you can do some joint count, but I think that's too, fluffy. And I don't do that. I'm focusing on what are your complaints, what are your concerns, and what we can do about it. Yeah. And then most of the time, we can figure out that in a follow-up appointment, yes, the inflammatory part probably is okay. And then the questions about fatigue and physical function comes up. And I must say, because in my experience, the physician is always a little delayed in getting to the virtual appointment. When you have a hybrid clinic where you're, when you're seeing patients physically, you're always a little late. But the virtual appointment starts at 11 and they're already there. Yeah. And as you're waiting for the doctor, you're thinking and preparing in your own comfort, right? Most of the time it's at home. Yeah. So that gives you a comfort level that you can actually start asking the right questions and having the discussion. So most of the virtual appointments, I used to imagine, I'm not going to do the physical exam, so it's going to be just 15 minutes, I'll be quick. But they're longer. There's longer. They're longer. There's a lot more conversation. But
that's a good thing,
right? That's a good thing, yeah. So I think, and that's why, the encounters that we have, say in a year, it's about 3 or 4 times. Yeah. If at least 1 or 2 is virtual, I think we spend time talking about what concerns the patient. So it becomes more patient-centric. And of course, when we see them, we'll medically examine and And I think that combination, that hybrid assessment is great. And also, I think from a triage perspective, nowadays a triage is based on what the family physician has said, or it's not perfect, right? So what I'm trying to do is to get that, you get a referral, and then maybe you can have a quick assessment or virtually, which also
to fill it, to color inside the lines.
So how urgent is it? Maybe it can wait or not, because it's many times these referral, even if you have criteria for referral, I don't think it works that way. You just have to have that conversation. And maybe the nurse practitioner or a fellow in the clinic could do that and then say, hey, this is really urgent, you need to see next week. Versus, yes, this could wait a few months. And so that's one touch point. And then you actually see, and we can also figure out what investigations need to be done
prior to the visit.
So I hate these panels. Oh, let's do an arthritis panel. Let's do a whole body X-ray. That's really waste of resources. And we can focus those based on the history and maybe add on something after your physical exam. And then most of the time we do not make a decision right away. Like sometimes it's, oh yes, this is RA, no other differential, let's start your methotrexate. But most of the time it's like, okay, let's look at your other blood work, let's see how your liver functions, and let's discuss this the next visit, which could be the next week or a week later once all the investigations are in, and then you don't have to miss a day's work, come all the way back to have that meeting with your doc. You can do that virtually.
So this is actually quite amazing. It's what you've just described in real life with you and your patients is a completely new element to the model of care. And we've all had to together learn how it should work. You know, there are good, bad, and mediocre examples of everything in life. But what I really like about it in some ways, though I know I'm a big evidence-based supporter in terms of what you do in your clinical practice and what I'm supposed to do in my life with the disease, the use of virtual care and the future role of it, certainly in the early days, the development was organic. It was a bit trial and error together. And I happen to think there are a lot of ancillary benefits to that, which is a new discovery of certain elements of your relationship with your practitioner, with your doctor, right? We've learned how to talk better together, I think, in that virtual world. And hopefully people out there in audience land are going to feel more comfortable when they do go into clinic. So that confidence they had to share concerns in a virtual world, hopefully they're going to be able to pull that into the clinical setting with you. That's super exciting. We know you've got lots to do, so we're going to wrap with a couple of questions about what you are very expert in, and that is treating people who come to you with either suspected disease or group of diseases and spondyloarthropathies. What excites you as a clinical researcher and as a clinician? What excites you today about the area in which you're working?
Right. So I deal with a type of spondyloarthritis mostly. It's called psoriatic arthritis. And spondyloarthritis is an intriguing group of diseases. You have on one end of the spectrum people with bad spinal involvement, stiff bamboo spine, and on the other end very deforming arthritis of the peripheral joints, and a mix of all that. And there's also the intersection of multiple, from a medical point of view, specialties. So many of the patients would have inflammatory eye disease, skin disease like psoriasis, and inflammatory bowel disease. So many times it's not just the rheumatologist who can make the diagnosis, or at least assess the whole patient. You need to talk to the gastroenterologist, talk to the ophthalmologist, the dermatologist. So it's already multidisciplinary. And then of course, like in most of the diseases, but particularly when associated with psoriasis, there is also the element of metabolic syndrome and obesity and significant mental health challenges. So it's a complex kind of disease, and thankfully, over the last 20 years or so, we have lots of drugs that benefit the disease. And I must say, 10, 15 years ago, it was like, oh, we need to get into a biologic therapy, and then everything's going to be fine. And initially, when people got into biologic therapy for the first 10 First 5 years, most people responded really well, and everything was, we thought, oh yes, we have the solution for this disease.
Right.
But then as time went on, we realized drug failures become an increasing challenge.
Yeah.
So now when we manage disease, it's about assessing the disease properly and deciding what drug to use. And because of many options, we have the luxury of choosing them. And then the question is, how do we choose the right drug?
Right.
Which is a work in progress, and hopefully with the newer technology that we mentioned earlier on, that would be a reality. Today at the ASM in the morning, Dr. John Isaacs was talking about the similar approach in rheumatoid arthritis. And one of the questions he raises, do we really want to know which drug is going to work best or which drug to avoid, right?
Oh.
So maybe you know that this drug is not going to work for you. That's important knowledge. And instead of finding the right drug, finding the right avoidance would be something to think about. So, and it's a work in progress, and hopefully we'll get somewhat better in predicting the best or a group of drugs that's for a particular person, personalized medicine. And the other challenge more recently that's being recognized, not only in psoriatic and ankylosing spondylitis and other axial spondyloarthritis, but also in rheumatoid. As the years have gone by, there are a significant subset, thankfully not everybody, but a group of patients who have not responded.
Right.
So-called difficult to treat. And that's become an increasing focus. So, quotes from my patients are like, oh, I was thinking this biologic is going to, change my life, and this is the third biologic, and nothing.
You start to get really depressed about it,
discouraged, and then you're always, no, I'm sure there's a right drug for you, let's find it. And so, difficult to treat, difficult to manage disease, and there are many aspects to it. So, if your diagnosis is delayed, you've been suffering from pain for a long time, your brain gets altered because of chronic pain.
Yeah.
And although your inflammation is better, you still are not feeling better, right?
Yeah.
So central sensitization, fibromyalgia, what do you want to call it? That's a big problem. When you have other diseases like the skin and gut involvement, you have challenge if one responds, one does not respond. Some drugs are good for something, some drugs can make it worse. And so these are interesting challenges. It is accumulating as more and more patients are getting diagnosed. So we need to challenge. We need to diagnose early. We need to find the right drug or avoid the wrong drug.
Right.
And then treat these accumulating problems over time so that overall life gets better. So big challenges, but I think we'll get there.
Yeah, it sounds like the science is certainly advanced. And interestingly, we've had lots of other health professionals here from different disciplines in the studio over the last 3 days talking about these same problems, but from different specialty areas, right? Exercise, diet, mental health, self-empowerment, self-powerment. All of these things do go together. Your skill and my skill as a patient, frankly, coming together as a village and tackling these problems in a really, I think, better conversational way. I hope that's the byproduct of the COVID era, right? Yeah. We can't thank you enough for coming in. Are there any questions, Anita?
Do you have any self-care tips for people living with spondyloarthritis?
Exercise?
Exercise. Good sleep, good exercise. I know it's easy for me to say that, but if you can find with the help of, your social support network, that's going to make a big difference.
Yeah. The Canadian Rheumatology Association has good patient information.
Yes.
We have good patient information on our site about exercise. We have great videos on our Arthritis at Home programming. We have older videos actually from this meeting that address this topic. And we will post those for you so that you can dig into some more resources. Thank you so much, everyone, for joining. Dr. Chandran, thank you so much for coming in. We're going to let you scurry off. We know you got lots to do. We have one more interview with a very special guest, our partner and co-power of the Arthritis Broadcast Network, coming into the studio next. Stay tuned.